Good evening, everybody. We've got a rather an exciting project tonight. It's slightly off beam because we're going to be showing a few videos of something which used to be called science fiction, but is probably more likely to be called science faction because more and more people are taking on the idea of the robot. But it's something that hospitals have probably pioneered, and we're going to be having two extremely good speakers. We've got CEO of the St. Mark's Foundation, Jason Bacon. I think many of you know of him. We write about him a lot in Raw, for instance, his exploits. And we've also got a very intelligent and very clever man with a fellowship. There are not many of those around, who will be telling you and answering questions about robotics and robotic surgery. His name is Kapil Sahnan. I hope I pronounced it right, Kapil. Great, great. Right, well, over to you, young Jason, and very much looking forward to your talk and video.
Thank you very much. Make sure everyone can hear me. I think you can, hopefully. Thank you very much, Gary and Chris, for the introduction, and really thank you very much, Caps, a very busy surgeon, for joining us as well. This would not be the same without you here. And welcome, everybody. Before I start, I just wanted to see if we can do a bit of a hands up, if everyone can use the hands up function. If you have heard of robotic surgery. Or you can put your hand up physically. Seeing a few hands go up. And then I was going to ask you, not many, more hands coming up. Now, those of you who put your hands up, I would like you to keep them up if you think you know exactly what it is. I wonder if any hands are going down. A few hands are going down, some hands. Anyway, I thought it'd just be interesting and also to know, and also to make sure that what we're going to talk about is interesting. I think it's interesting. It's what's really interesting about it is sort of the journey of surgery as well, putting it into the wider context. So really what I want to do to start with is talk a little bit about that context. Obviously, surgery in its many guises has been around for a long time. Until I think it's the mid-90s. I'm sure Caps is going to correct me on some of these, but until sort of the early 90s, late 80s, early 90s, most surgery was done openly. And that's just a tradition, that's what we all know of surgery being open surgery, with the surgeons opening the patient up and doing their surgery of all kinds, especially bowel and colorectal surgery. When laparoscopic surgery came in, commonly called keyhole surgery, interestingly, St. Mark's was not particularly an early adopter of that at laparoscopic. And I don't know the reason for that. Caps, it was probably, I'm not sure Caps was around there. It was probably before his time. But anyway, we weren't particularly innovative at the time. We were late to it. Now, part of the reason is that St. Mark's has always had very leading surgeons in their field, and very good surgeons, competent surgeons. And at the time, the open surgeons felt it was quite extraordinary that you could put tools into a patient. Sometimes they refer to them as chopsticks because they're all they're rigid in a sense, and then it's by keyhole, but the surgeons are looking at a screen, and so they're not actually looking inside the patient. And then some of the open surgeons found that extraordinary, that you could actually do a surgery that way, and they were reluctant to move to that. But laparoscopy, certainly at St. Mark's, is a very common way to do surgery. What robotic surgery is I always think of it as enhanced laparoscopic surgery, and it's called a robotic surgery. The company that's pioneered the development of robotic surgery is called Intuitive, and they make a device, a robotic tool called a Da Vinci. And we'll talk a little bit about competition and how they've ended up in their position, but they're the much dominant player in the world in robotic surgery. And they didn't call it a robot. I think the media and the press and maybe in healthcare, people started referring to it as a robot, and it's not a robot. Danilo has a slide. Danilo Miskovich is one of our leading surgeons and has led the robotic program at St. Mark's. And he always has an opening slide that says, "A fool with a tool is still a fool." The robotic surgery requires a surgeon. The difference is the surgeon is remote to the tools that are in the patient. And I'm going to show some videos in a minute that will demonstrate this. But the surgeon is remote to the patient using a console. I'm not going to describe the surgery. Watch the videos first, and the Caps is going to come in as well. We can describe in much more detail about what the benefits are and how it works. But that's essentially what a robotic surgery tool is. The laparoscopic tools go into the patient, and the surgeon is remote to the patient using a console. And there are very many advantages of doing that we can go into. We at the foundation helped the hospital purchase a robot. We funded almost 2/3 of the cost. They run at about £2 million each. They have been very heavily used originally in urology and gynecology surgery, prostate surgery. Even 5 or 6 years ago, over 90% of prostate operations in the UK were done with the Da Vinci. And in most hospitals, that's what they were used for. Some head and neck surgery, some gynae surgery, and a lot of urology. So in most large hospitals, the urologists kind of cornered the robotic surgery tool, and the colorectal surgeons literally didn't get a look in. At St. Mark's, even when the robotic tool was at the Northbit Park site, there wasn't a lot of urology going on. There was some. So our mission was to have a robot dedicated to colorectal surgery, which allowed a high volume of surgery to go through robotics, train a lot of surgeons to use it. And at one point, we were doing a higher percentage of our overall colorectal resection cases with robotic surgery, higher percentage than the US average. And I'm happy to answer questions a bit about the program, about the benefits, and about some of the journey we've been on for the last few years with Intuitive as we pioneered robotic surgery for colorectal. So I thought I'd pause now, and I'll apologize. We're going to show 4 videos. I'm going to have to share screen and unshare to show them. I would urge you all, please, not to record using a mobile device or any other device to record the screen. These are all videos that took place in a live theater with a live patient. You won't see very much, but I will, if anyone does feel they might be a little bit squeamish, please feel free to look away, but you don't really see much at all of the patient. So it's not too dramatic in that sense. These patients all consented to have visitors in the theater, but in terms of showing the video, I just would prefer if people didn't record it. But it's the best way to really see what it's all about. And we might just pause it after each one, and I can describe what you've seen. And then in fact, before I even start, Kapil, was there anything you wanted to mention about the history of surgery and the move from open to laparoscopy to robotics? Have I missed anything? I'm sure I
No,
have.
I think it was great. I might just add a few bits in, if that's all right. So my name, you're very welcome to call me Caps. It's what everyone does. I joined St. Mark's in January as one of the new robotic IBD surgeons. And when St. Mark's first started, we had very, very good surgeons, some of the best surgeons in the whole country. And when I say the best, we do that based on our results. How good were our cancer operations? How many patients needed chemotherapy? How good were our IBD operations in terms of, did we get out what we wanted? And did we cause any damage when we were doing it? So when laparoscopic surgery first came in, many of our surgeons looked at the early data and said, the outcomes are not comparable. We're not as good laparoscopically or with keyhole surgery as we are open. And what we want to provide our patients is the very best of our ability, and it isn't yet there laparoscopically. Then St. Mark's employed Robin Kennedy, who some of you may have met. He's recently retired, and he was the big laparoscopic surgeon from Somerset. And he set up an international program called LAPCO, basically teaching people how to use this new tool. And that's what it became. It became a fancy new tool that everybody was keen to try, but really without any evidence and really without any training. As robotic surgery has come, we've learned from some of the mistakes we made with the advent of laparoscopic surgery, not just to let everyone have a go, because that's what it was for a period of time, but really to make sure people were trained, they understood the operation they were doing, and then separately, as a separate facet, they learned how to use this new tool. And the other thing that you should know is, as of yet, in colorectal surgery, we have shown no trial evidence to suggest it's a better outcome than open surgery or laparoscopic surgery. There is more data coming out now to suggest that the length of stay is better, but that's really with laparoscopic surgery as well. So how we're going to show the benefit of the robot is kind of a conversation that is ongoing amongst many of the academics, and that's something that Danilo and I and many of us are looking to show. If you were to ask me what I think that benefit is, it is just a better understanding of the operation we do. So the three benefits of the robot. So I've got two children, so sometimes we play guns. I know we shouldn't, but we do. And if you were all to take your hand now and point at your screen, showing me that you were going to shoot me, it would be really useful. So I'll show you why robotic surgery is better. You will only be able to turn your hand that much to do a sideways shoot, and then you won't really be able to do very much more. So laparoscopic, and if you turn it the other way, you'll be restricted as well. With the robot, I can go all the way around without any issue. And that may seem very kind of menial to you, but when you're stuck and you can't move something more than you can, or perhaps you're holding on to a bleeding vessel, having the full movement is essential. The second example is the vision. And so a non-gendered example of this would be either a husband and wife driving, either one of them driving, asking the other for instructions, which way do I go? And you always feel the other person is not giving you their very best. That's how we sometimes feel with our assistants when we're asking them to hold our cameras when we're using the chopsticks. Here, the surgeon controls the camera as well. So we have, at the moment, as I've described it, 3 arms, 2 operating arms, and a camera that we can also control. As surgery becomes more complex, we want to have another person to help us. And again, we are relying on a trainee to come and do something else and say, what would really help me would be for you to also lift this up so I can cut underneath it. Now, your trainee is only as good as your trainee is, and it's quite hard to do that. But now let's say I'm in charge of that as well. So it is kind of like the ghost analogy, the Demi Moore thing, where you can have extra hands helping you do exactly what you want to. And those are kind of the 3 main examples of why the robotic system is better. Theorizing after that to what that allows you to do. So the vision is the key thing. So if I look at pouch surgery, for example, one of the key things that puts people off pelvic surgery or pouch surgery is damage to your nerves. And we say that it's very difficult to see where the nerves lie. Now, if this is your rectum and these are the nerves underneath, if there's lots of inflammation, and that's because it's quite difficult laparoscopically. It's not impossible, but it's quite difficult. And you've got amazing surgeons, such as all the surgeons you know at St. Mark's and others, who can do that distinction very well because they are trained to look for that. The robot simply gives you an augmented version of that. We can zoom in 8 times. We are looking right there at the nerves. So we can see them, these big kind of cables, if you were, to know that those are nerves and those are things that we need to really push down out of our surgical field so we can go and do our operation. The last bit is, the best way to think about this is if you drop your wedding ring at the bottom of a flower vase, your hand gets stuck and you can't do very much. If it's a very deep vase, you're stuck and you've got limited movement and now no vision. The robotic system allows you to put all of your arms down and to work in very tiny confined spaces. So your tiny confined space that we're talking about is the bones that make your pelvis. And that's where the advantage is, in my opinion, of robotic surgery. It's any operation that happens in the pelvis. Urologists found this first because their prostatectomies, or when they remove the prostate, which is a very common operation for them, is an operation which is confined in space, and they were always struggling and fighting. And if you can imagine two second row surgeons both trying to hustle and bustle against each other as they're trying to get space, they are constantly clashing. With the robotic system, it is designed not to clash. And now I shall be quiet and
No,
let's look at some video.
Caps, that was unbelievable. Again, this is why you're here tonight. In fact, you've just led me to think about a couple of things. That amplified view, am I right that the view that you have is actually amplified? So
it's amplified, and then it's 3D.
Those tools, we'll see it on the screen in a minute, but the tools look quite big when you're looking at the screen, but actually what's in the patient, they're tiny.
Super tiny. And the other thing that we get is 3D vision. So when you are going to look at this screen, you'll see it in 2D. So everybody in theatre will be looking at a 2D screen, apart from the surgeon, who basically immerses themselves forward in a simulator, which we'll hopefully see pictures of. And it is our own special zone. We have a microphone that is over here that we can talk to and people can hear us. And the vision that we have is phenomenal. So what you might see on the screen might look like a normal TV screen, but what we see is a super enhanced picture.
I've heard surgeons talk about another benefit, which is the fact that you're sitting down and often doing very long operations. What are your thoughts on that?
Yes. So it is physically demanding operating. It is tiring. And if you are, so I keep picking rugby analogies. So if you are operating on a second row forward, you are walking up and down their abdomen and you are struggling to bring their pouch down to their pelvis. That is a struggle. If you are operating on, let's say, a hooker, you are fighting deep down into their abdomen and trying to do a very difficult, minute hand skill through all of that. And that is exhausting. And the best way that I ever think about it is we just become used to it. We just become used to coming home with super sore shoulders. And over time, we build what has been classically described as operative stamina. And many surgeons, if we look at back days and how many times they have to go off for slip discs, it is way and above any other profession. It's just that we're used to it. And we also contort ourselves into funny positions to allow ourselves to do part of the operation. A proposed benefit of robotic surgery is you can keep surgeons for longer. So since we're all never going to be allowed to retire until we're kind of mid-70s, we can do it. But the other advantage is that we haven't talked about is the whole concept of remote surgery. In whatever profession you are, you become an expert just before the time you retire. And we say to you, have a lovely retirement, but actually all that wealth of information goes as soon as you go. But at the moment, so I've not done this yet, but Danilo Miskovic, one of the robotic leads for cancer, he will supervise an operation from another country. Mm. And he can just log into the system and he can say, right, what I think is going on here is this and this. And he can speak directly to the surgeon at the console. And it's amazing. When you train another trainee, so I was training yesterday, we have two systems. Not every hospital has two systems, but we're very lucky with the foundation support to have two. So one surgeon is on here, and I, as the consultant, I'm in the other room, the other console in the same room, maybe just the other side of each other. And I am able to talk to my trainee. I'm able to draw on the screen. I can take control of one of her hands. She was a female yesterday. So she can classically operate with two hands. I can take control of the camera. So in terms of enhanced teaching and assistance, I'm basically doing that for them. So I have a 6-year-old and a 4-year-old, and almost all of the things that I teach them are so much easier if I were to have a robot. And it's how we teach them to make sandwiches or to cut their food. We hold their hands, we put the fork down and move that. That is replicated in the robot. It is not replicated in laparoscopic surgery because you have to move it to a certain ability to be able to do the task. Once you let go, it falls back down. But here you're able to really, train them to understand what that is involved in.
I was going to pick up on a couple of other things before we see the video. This whole aspect of the restriction of the dexterity of the wrists, and it was very interesting. Quite early on in my tenure at St Mark's, I sat in on in fact, I think it was the first one I was involved in with one of our funders, and one of the laparoscopic surgeons at St Mark's, very, very proficient laparoscopic surgeon, was using the robot, maybe not for the first time, but he was being proctored by Danilo. And he was, as Caps has described, there were two consoles, and he was operating on one, and the other surgeon was directing him and advising him. And I could hear the surgeon say, I'm going to go and do this, but I can't really get around here. And he used those words. And the proctor said, Danilo said, no, you can go there. And he did. And he went, oh. So I heard a surgeon go, he was surprised that something he could do that he wasn't expecting to be able to do with his traditional tools. And I just think I remembered that a lot. And I thought that was interesting. I've just heard the benefits of robotic surgery. Back to Caps's point, putting that into data and justifying business cases for more robots is very difficult. But I think that's probably where we're at now, is that you can do more with the robot. And the other thing about benefits, of course, is as Caps was describing, the benefits from open to laparoscopy are very pronounced, because the difference between opening a patient up and doing it through keyhole surgery in terms of infection risk and how many nights in hospital after surgery and your general recovery, there's a pronounced difference. From laparoscopy to robotic laparoscopy, the benefits are much less high. That's partly where we are with the journey. Why don't we show the videos? So Caps, that last one, you could really see the surgeon, using the console tools and moving their wrists around.
Yes, you can. So you can. It's very difficult to describe what it is, but essentially you're operating with your 3 fingers, and you put your hands into almost the robot's hands. The robot shakes your hand, if you will, and you put them in, and you move your hands in various moves, and that replicates the movement the robot does. The advantage that you have is you're operating in this space, perhaps the space that I've got my hands to you, but I can move my robotic arms further than that, because I can clutch it. Clutching means I stop the robot moving. I move my arm back to here, and I can unclutch it and move it back. I can clutch it again and do that. So I can move through the whole abdomen by extending the arm of the robot to do that. And it's wristed at the wrist, the elbow, and the shoulder, similar to a human arm. Does that make sense? So I can operate like this, and I can also operate all the way at the extension of my arm.
Brilliant, absolutely. So I think maybe a good time to take questions, Gary and Chris, if you think. I mean, yes. I'm seeing one question about I know Kapil's answered it in terms of how remote the surgeon could be. It's a very good question, because you saw those consoles and the tools within the patient in the same room. Back at Northwick, actually, the consoles were in a separate room, a room adjacent to the surgical theatre. There was quite a large door opening between, so the surgeon could actually look into the theatre and could talk to the theatre staff. The theatre staff could talk to him or her. But as strong as the internet is the answer theoretically, and I believe Intuitive have been some trials with it. But you could have the consoles in a different country now to the theatre. Now that opens a question of access, which sounds wonderful, because you could have really competent surgeons in one country, and you could have on the other side of the world a patient needing operation. The thoughts on that, however, is that hospital in the other side of the world would have to have a Da Vinci, which is quite expensive. So if you can get the Da Vinci somewhere where it's needed, then the surgeon could be remote. But as of now, I would say that certainly within the NHS, and I think in the United States and elsewhere in the world, the robotic tools and the patient are in the same room or adjacent to the surgeons and the consoles.
Okay, lovely. Another question. When was the first robotic pouch operation, would you say?
So we did our series and wrote it up, Omar Faze and myself, and our first case was in 2019. And Omar does them with Danilo. So the people who do the robotic pouches are Omar and Danilo. Yes. Danilo does a laparoscopic pouch, and I do a bit of both depending on who I'm operating with.
Okay. I think perhaps we were I think St. Mark's was the first pouch surgery using the robot. in the UK. I'm not 100% sure, but
So
I
we
think
were the first in the UK, and we were the first published in the world. I'm not sure if people did it in America prior to us, but didn't write it up.
Okay.
That goes back to the whole concept of why we're doing this. We
Sure.
are all interested in good surgery with good outcomes. How we do it is relevant. And so whether we bring a new technique in, it is only useful to us if we are pioneering and evaluating.
And doing it well, as you say.
Exactly.
Yes. Yeah. There must be more questions. Please send in your questions.
So if I go through I might just expand on the remote aspect, because I think it's really important.
Yes, that would be splendid, yeah.
So when we operate on patients, we cover them, their face, and we operate on the field that we want to. That's for kind of the whole issue of infection control. But also, if you could imagine a situation where we were operating, and I'll pick up a heartstring example. If I was operating on a child and I was having an issue of some sort, and I was to glance at that child's face and remind myself that actually I've got a 4-year-old in front of me, that would be very distracting.
Yes.
So the concept of when we operate on people and the ethics of what that looks like is really unusual. If I'm operating on somebody with a robotic system and there is a thing that goes wrong, because things can go wrong, I'm able to de-dock that robot in about 5 seconds, open that patient and do what I need to make the patient safe. And there is a lot for that. The concept of remote proctoring, or teaching another already competent surgeon to do something, is you have another competent person who can do that. The robotic system was designed for warfare. It was designed for the battlefield. And if you were to have a wounded soldier and you could send the robot to pick it up and perhaps start that early form of resuscitation or stopping a bleeding vessel or whatever.
Yeah.
If you were to say, is there a future where people would go into a pod somewhere and we would just, maneuver the arms and do the operation? I think the ethics of that would be very difficult, and it wouldn't be widespread. We would probably do it for space surgery. If somebody needs to have an operation on a space station, we could do that. We could have an anaesthetist be able to put the patient safely to sleep and be able to safely wake them up. We would need a less trained individual to put the robot system on, and then we could do everything we wanted to. So that's my answer for how remote the surgeon can be. So the answer is as remote as you want, but perhaps we don't want to be remote. We want to be near our patients.
Of course.
Because we're not all control freaks, but most of us are.
Hey, Chris, I don't know if you're asking all the questions, Chris. I'll put
yes, please.
Coming in. Somebody is asking, how fine can the work be? Do you have to sew a pouch? Do you craft a pouch robotic?
So we can make the work more far, beautifully. It's a really lovely video by Intuitive. If you can imagine a grape, they pin with a drawing pin the grape to it so it doesn't move. With the robotic system, I can take the skin or a lips of the skin off the grape without damaging the inside, and then stitch it with the finest thread I can find back. So you find it very difficult to see that we've been there. You would see the knots at the other end, but we can go as fine as you want to.
There's another question which was very similar, which was how delicately can you're using a stick? I mean, I find amazing you can.
You're breaking up a bit, Gary.
Yeah, sorry, Gary, I didn't hear the whole of that. The question about how do you have to?
How delicately can it be controlled when you're using a joystick?
Yeah, the joystick is your hand. So if you do this, the robot arm will do that. And if you were to have a tremor, some people have tremors, it would control for that tremor.
Yeah.
So you have to be very careful with the robot because you have the power of the robot.
Yeah.
It's very sensitive, but it will also augment your movements. So if you want to only do a tiny movement, you can set it in such a way that your tiniest movement is enhanced a lot, or the other way around. So a big hand movement the surgeon make only generates a small movement on the
Does
robotic.
that mean it can almost be personalized, Cap? So that some surgeons who do like to be more dramatic with the movements, others who are more subtle, can you actually personalize the console for each surgeon?
So yeah, so you can to a degree. So we personalize how high the viewer is, how high our arms are, how long we sit in, and all of those things, and whether we sit like this, sit straight, or sit forward, as if we're in some sort of, head forward racing car, like a motorbike, I suppose. We can choose that. On top of that, we can choose the speed that we want our movements to occur in. Most of us don't fiddle with that. I'm quite interested in the concept of how we develop engineering to do this. And so I have played with that, and it's quite interesting. You can change your movement so the slowest movement becomes quite fast. So you can speed your arms up, which I don't like, or you can keep it normal pace, or you can slow it down if you so wanted to.
Interesting. Somebody's asked a very interesting question, which is, how about for pouch removal?
Yeah. Okay. So one of the hardest operations that we do as IBD surgeons is to remove a J pouch, mainly because the operation has been put in through an open operation, so a big old cut through the middle, which means we will only have scar tissue. So in order to do it then minimally invasive, either laparoscopically or robotically, it's possible, but it will take us a longer time and therefore increase the risk of complications to do so, but it's not impossible. It's not impossible. The second aspect is why you're removing it. So if you're removing a normal pouch without any infection all the way around it, the removal in the pelvis is okay. It's as okay as it can be because there is nothing around it. If you had a leak, an infection has come outside of your joint, your pelvis will be full of scar tissue, what we call fibrosis and infection.
Right.
Surgeons are only interested in planes between structures, and that is looking at a cake that you cut in. We want to know what the sponge, the jam, the sponge, the jam, and we want to operate in very fine areas. When we get lots of infection and fibrosis, we lose our navigation.
Right.
Because we can't work out, and it all just looks like a white, hard bit of tissue.
Yeah.
We work around that by not tackling it in a single aspect here. We would operate around it like this and come down and up at another angle. That's how we get through it.
Right.
But those are the difficulties of pouch excision. With the robotic system, you have the advantage of the better pelvic access and better vision.
Right.
So it is possible to remove a pouch robotically, but it has to be under the right circumstances.
Yeah.
So I'm a big keen advocate for the robot. I had done 3 pouch excisions this year, and none of them, even though I think it's my preferred choice of operating, I've listed for robotic removal because I know that it isn't the best. I would take longer doing it to get rid of all of the scar tissue, and the safer thing would be to do a safer and quick operation. Omar and Danilo have taken a handful out robotically because they have been suitable for doing it. And that's a conversation I would have with somebody in clinic. And that's if anybody is considering that. It again, it isn't to do with the tool, it's to do with the safety of the operation and getting good outcomes. However, that might happen. And we would talk about it in clinic and would say, this is the pro for it and against. And if you were ever to have a minimally invasive pouch excision, I think what the surgeon always needs to do, and we all do it at St Mark's, is understand at which point we should bail and convert to a traditional operation. That becomes very hard when you're task oriented, and there are lots of kind of psychometric tests that show when you are focused and you are doing nothing but this, your concept of time is eroded. What you think has taken 3 minutes has actually taken, half an hour, but you don't know that because you are in the moment. So what we often do is we ask our anaesthetists who are remote from us to say, I am now going to do a difficult aspect of this operation. At half an hour, I want you to tell me to stop, and I want to step away from my operation and evaluate whether I've made the progress that I think I should. And if I haven't, I need to act in the best interest of the patient, not my ego to feel that I can complete the operation using this tool or that tool. There is no ego there at all. And as soon as we introduce that, we don't do the best job that we could.
Sure. No, that's a very good answer. Right.
There's a question about how long does it take to change the piece of equipment on an arm if you need a different implement, which is an interesting one because there's quite a few implements already in the patient.
So you have 3 instruments, or you've got 4 things in them. To take out my index finger, I have to make sure it's safe, not holding anything. I press a button and pull it out. That takes 3 seconds. I then put a new instrument in. To load it in takes 3 seconds. There you go. The robotic system then needs to recognize what I've put into that arm. So it knows that it's dealing with a stapler or a pair of scissors or a grasper. That process takes about 5 seconds. And then you can push it into the exact same spot you left it. So it has a 3D stereotactic way of understanding. So if I'm operating at the very bottom of my flower vase, and I'm about a centimetre from a very important blood vessel that if I were to damage it, it would cause catastrophic bleeding, the robot would stop at the last point. And if you were to push it without looking, it would stop exactly where it was told to stop. We don't always do that because things move and we move and all of that, but that's how the robotic system has been designed.
Yes.
So the answer in total is about 20 seconds.
Extraordinary.
Chris, I'm supposed to be an assistant presenter here, but am I allowed to ask a question?
Yeah.
Please do so.
I'd love to ask Caps about the future. You know, what are things going to be look like in 10 years, 20 years? And as I ask that, I would love his thoughts on something I heard from a director of a medical program in the US, not a robotic program, an entire hospital system in North Carolina. And they have a lot of Da Vinci's there. They've been using them for a long time. He said, one of our biggest challenges, we have to train the younger surgeons how to do open surgery. So these are young surgeons, all they know is laparoscopy and robotic. They've never done open surgery. So Caps mentioned that occasionally you will have to undock the patient and open them up. And they're having to make sure that the surgeons there, which sounds kind of crazy, but they have to learn what that means to look into a patient, open them up. And I don't know if that was an exaggeration, but they were actually saying that he has to make sure that for emergencies that everyone's trained to be able to do open surgery. But just in that context, you know, obviously artificial intelligence is a hot topic and it is used in endoscopy a little bit. And I think in robotic laparoscopy, there's a slight tool that's used a bit to help you. Maybe you can elaborate on that. But what's it going to be like in 10, 20 years time? Well, where are we going? We're going to be talking to you in 10 years time. You're not out of business yet.
So to go back to very quickly before I answer the more exciting question, just so I've done it justice to all of it. Most of us are trained in laparoscopic surgery now more than open surgery. We seek out opportunities. So St Mark's is a great opportunity. So I came here slightly earlier as a PhD candidate and then as a fellow. And I worked for people who did lots of open surgery to get my hand in. My basic training is laparoscopic surgery. And in order to be better than the UK, because we were relatively slow to adopt compared to other countries, I left to go to Spain and Barcelona, where they have like 4 Da Vinci's. So the first thing that will improve in the next 10 years is access. All of us will have robotic systems. St Mark's is the first in the world to have a sole robotic program based around the every aspect of colorectal surgery. So we have simple cancers being taken out, IBD being operated on, advanced cancers, pelvic floor surgery. There's no other hospital in the world that can now do that. So we are far ahead of everyone else. So the first thing that will happen is it will become more ubiquitous. We'll have cheaper systems. Everybody will have it. I hope to run a PhD, not this year, but maybe next year, in virtual reality and mixed reality. So virtual reality is when you put a headset on and you are in that world. Mixed reality is you put a clear HoloLens on like your normal glasses and that world is projected in front of you. So if we think about all aspects of the patient's journey, so preoperatively, I think that we will consent patients, or I am going to do this during my next 5 years, using mixed reality and virtual reality. So pouch surgery being a great example. So that's a PhD that's starting in October. How do we ask somebody what to do? How do we possibly even give them any understanding in their 20s or 30s about this ridiculously complicated notion of a future of a life? We do it as well as we can, but that's not good enough. There are people doing it better everywhere, and people doing it with better, who are better educated and better read, and they don't have the red line group, for example. So number one is preoperatively, we will counsel patients so they will genuinely know as much as we do about why they're having it. We will walk them through their operation, all the scary parts of it being in hospital. So there was a study using virtual reality in pediatric patients going down to surgery in Singapore. They measured their heart rate as they went down, and without it, their heart rate was jumping up. When they were able to calm them down and bring them through, they were doing brilliantly. So we will, I imagine, or I hope, have more spa-like environments, and all of you will think about your times in hospitals, going through some of the most challenging aspects of your life and how stressful it was. People are running around, they're asking you if your name is this and it's not that, and they're asking if you've eaten and done this, and then they remind you of your consent form and the risk of all of these miserable things. I don't know why we do that. There's often a fire alarm that comes off at the same time, and all that we're doing to you is stressing your bodies out, and your cortisol levels are rising and rising and rising. Quite why we're not paying Enya and beautiful aromas are coming through and the mood, why aren't we doing that to calm you down beforehand? We then come into the operating theatre. First of all, we don't need as many people in the operating theatre. We have a beautiful robotic system that is calm away from you that you don't see. We can operate virtually with other people around the world who can join us as avatars. So like the film Avatar, we will have a hologram type of Superman 1, Superman 2 person there taking you through your surgery and walking you through that. When we come in, we will know your latest radiology, not because we're walking to the screen and scrolling down on a 2D print, because I'm projecting it onto the body that is anesthetized and sleeping in front of me. I'm then thinking about the very specifics of that operation in greater detail than I've ever done beforehand. Those nerves, that 50% risk of not having children after pouch surgery, that's what we've traditionally quoted people, and we've reduced that down to 30, but I can already draw those on my screen, and when I'm there, I can say, look, there they are. And I can point to the robotic system and say, those are the nerves. Remember that those are the nerves, and if I come anywhere near them, throw me a little flashing warning. So every aspect of my operation are then being augmented based on my outcomes. Time taken to do different tasks. So for example, the first part of the operation may be taking one of the blood vessels. I know in my mind that should take 5 minutes. If it's taking 10 minutes, the robotic system will prompt me and say, hey, you're taking 10 minutes, you must be having a complication. Would you like me to try to throw back the radiology to show you why you might be doing that? Would you like me to show you an old video of what you've done differently beforehand, or even better, a ghost image? So I always think about Mario Kart, which I imagine none of you have played, but you basically do a time trial on yourself and you race against an old version of yourself. Well, I'd love that for my trainees. So the words that I say, I want you to lift this there and do that there. If they're not doing it, I would like them to have an overlay on the screen to show them, I mean, this to that, and all they have to do is just copy the dots. We are following the airline industry. We're not trying to make any decisions on the table. We're trying to make this as simple as possible. And that's all the system does. So that's what we would do. We would use, maybe in 20 years' time, will we have AI that does the operation? I don't know if ethically we would allow it, but theoretically that is absolutely possible.
Isn't some AI used, maybe I'm wrong, I know in the testing endoscopy, isn't there something where you put nodes in and the Da Vinci puts a little green cross where it thinks they should go, and then so there is a bit of AI used now, isn't there? Or maybe it's not AI.
So in endoscopy, so when the endoscopist is looking at a polyp to decide whether it should be removed or not, in Japan and now here, they're able to touch the end of that piece of tissue with the camera. The camera shoots a kind of topographic laser into it and tells it the percentage risk that that polyp has cancer. And if it is a low risk, it could be left, and it's a high risk, it could be taken out. We use fluorescence and ICG, and fluorescence is exactly as the word suggests. So for example, the ureter, the tube that connects your bladder to your kidneys, we can light that up by injecting dye into it. So when we are operating, we don't know what's what. That will shine bright and remind us that that was where the anatomy is, because often it isn't as easy as one thinks, and it can be covered in layers of internal body fat.
Yeah.
Well, that's a very good answer indeed. Fascinating.
And change is exponential. So even in healthcare, so maybe change starts happening quite quickly. We've alluded to the expense of these machines. When we funded it, there wasn't uniform endorsement of us getting Da Vinci into St. Mark's, and certainly the trust was a bit reluctant because they had to pick up all the cost of the maintenance and servicing. But as we speak now, the trust is now looking at buying 2 more robots, one to have at Northwood Park and one to have at Ealing. So things have changed quite quickly, and Caps mentioned the ubiquity and the access. And I think, I don't know the numbers off the top of my head, but in terms of number of Da Vincis and other companies are coming down the pipe. There's Cambridge CMS. I know that Google and Johnson & Johnson had one they were looking to make, and I think that didn't work out. But you're going to probably see a tipping point in the next couple of years where there'll be a lot more manufacturers, and then you'll get a real growth, because then the costs come down. Because right now, it's probably fair to say that Intuit have a bit of a monopoly on the market.
Yes. Interesting. Any more questions? This is your real golden opportunity to ask away. Yes, we have got one. Are you personally noticing any difference in how many patients are acquiring conversion to open surgery compared to laparoscopic surgery?
So the answer to the question written is no. The nuance of that question, though, is different, which is which parts of the operation can I complete before I have to open? The relevance of that is the size of the incision. So if I can do more of the operation keyhole and then open, then I can make a smaller incision. If with laparoscopic surgery, perhaps I would have converted earlier. So I'm converting slightly later.
Yes. There's another a slight follow-up here. It's not 100% linked to robotics, but what is the youngest age that you've created a J pouch for, or that St. Mark's, for instance, has done?
So I haven't got any great knowledge in pediatric pouches. Janindra Warisvatani, who I think most of you know very well,
Yes.
he has done some pediatric pouches. And I think he's done someone as young as kind of 14 or 15.
Yes.
The pediatric surgeons themselves, for not the conditions that we're talking about today, not ulcerative colitis or polyposis, but for things like Hirschsprungs, do create similar types of reservoir operations, but they aren't pouches. They're called something different, but they form a similar type of, or they have the same overall benefits.
Yes.
And they're young, you know, they are.
Yes, indeed.
Babies.
Yeah. Any more questions? No? Well, that was absolutely fascinating, and 2 very highbrow speakers. Thank you very much indeed for your time. And my goodness me, it's given us quite a lot to think about this evening. So thank you all for coming, and thank you both.
Well, one highbrow anyway, Chris. Caps, again, thank you very much for making the time. I've learned so much myself. Thank you.
Thank you, everybody.
Thank you very much indeed.
Really interesting.
Good.
Evening, all.
Evening, everybody, and sleep well.
Thanks, Caps. Gary and Chris, I'll catch up with you tomorrow. Thanks very much.
Oh, thank you,
Bye-bye.
everybody. Thank you so
Thank you
much.
very
That
much.
was so interesting.